your life if you're really hooked on that and believe that it's going to save you and really help you overcome cancer. So yes, believing something dearly will change the course of medical treatment, but of course we want to take them deeper to the God who does have the answer to why and how and when am I going to die, and the other kinds of questions that are going to come. So I know you're probably thinking that way. I'm not going to call on you because I got to move on. I'm sorry. Thank you for being willing, though. Okay. So, diseases that won't ever go away change the doctor-patient relationship. From simple to complex, from acute to chronic, patients become dependent upon you at some level. Watch out, letting them become too dependent, wanting to see you every week in the office, trying to overuse their time with you because you're the only friend they've got. That happened to me regularly, and I had to barrier myself from that. My nurses were good at shielding me sometimes. Most importantly, you have the opportunity to partner with them, and that's the key word right there. Become the friend against the disease and help them cope. Spiritually, you can gain that better than if you don't engage the spiritual. You can do better with this process of partnering if you can introduce the spiritual, such as helping live with the questions about why me? Why did this happen to me? How do I understand why this happened to me? Why could it not have been someone else? Why does it have to be me? It's suffering. I mean, I've had patients, screaming that in my office. There's no good answer to that question. That's where you have to say, I don't know. But I do know someone who has the answer. Unfortunately, they're mad at God right at that time, and you're going to have to help them morph over from anger to God and denial to acceptance and get past bargaining to the point of neutrality and ability to listen to God. You've got to walk them through that grief process. We are effective if we can help them find answers to other questions like, how can life go on with this? How can I learn from this? Maybe I could help others who've got the same disease. And what's God wanting to really teach me? I mean, it's not that He's punishing me now. Dr. Crane has helped me understand this is not punishment, that the statistics show that 7 to 10% of good people get this bad disease. It's not my fault. I didn't cause this, but God's not punishing me either. So what good can come out of this, right? Okay, giving hope and encouragement can be better than medicine. And pharmacists do that regularly, just like doctors do. Offering a listening ear is always critically important. If you're not interruptible and able to sit down with your patient, you're going to lose a lot of confidence. Let me show you a very important diagnostic, and it's a diagnostic technique. It's an ability to open up conversation and develop the history. It looks like this. The process is just simply this. Isn't that pretty easy? Yeah. Most of us want to do this. Okay, Ms. Jones, go. Tell me about your problem. I got 10 people waiting outside that door. Even if you spend 1 minute with Mrs. Jones like this versus like this, and you gently and appropriately put your hand on her hand or say, I'm really interested, can you tell me what's wrong? I want to hear this in your words. And you only let her go for 1 minute. And your nurse pages you out, or you've got an interruption or whatever. Both at the same amount of time. What's Mrs. Jones going to feel? She's going to feel that you spent more time with you like this or like this. What do you think? Of course, she's going to think that you have spent more time with her sitting down. Studies have been done to prove this. Exit polls from doctors' offices. Your patients always think that you spent more time with them if you sit down. So practice sitting down beside your patients, making eye contact, smiling, or being empathetic, and just listening. Involving and teaching family and friends is a very important part of chronic illness management. They're good investment. Okay, let's jump to a real case. I'm going to show you some pictures of chronic rheumatoid arthritis. I'm going to tell you that I have patients like this in my practice. I'm going to show you some of the disease pathology because I want to teach you some science here and show you some real good pictures. But I also want to try to get you to think about how you help patients go on with life who have stuff that looks like this. Okay, so here you've got classic. What is this deformity right here? I didn't hear you. That's a swan neck deformity. Looks like a swan's neck. That's a classic rheumatoid arthritis. What is this one called? That's a boutonniere deformity, as if someone is buttoning a button and their fingers are up, pinched like that. So those are the classic rheumatoid arthritis changes of the flexor and extensor tendons because of the damages of the disease. These are rheumatoid nodules, classic ones, and I've seen many of them in my lifetime. Rheumatoid arthritis is not just a joint disease. It involves the brain, it involves the lungs, it involves connective tissue of all sorts, it involves many tissues, predominantly, of course, the connective tissue, the bones and the tendons and such. But what do you know about this part of the body right here? The first and the second cervical vertebra. One's called the atlas and one's called the axis. How do they work with each other? Do you know that anatomy? Did you see it on a real cadaver? Have you seen a skeleton and studied this on a skeleton? What you don't understand with a skeleton is that there's a tendon that holds that process from whichever one it is, the atlas, the axis, the one that has the pointy thing that sticks down, the process that sticks down. There's a tendon, or a ligament, I should say, that holds that in place. And if that ligament is diseased, it gets soggy and flexible, which is classically what happens in rheumatoid arthritis, and it allows that to pith the spinal cord right behind it, so it allows flexibility. This is not the best picture. I also wanted to show you the loss of joint space here, and here, and here, and here. These intervertebral discs are just disease. This is classic synovitis, hyperblastic, hypertrophic synovial cells. Eventually there will be infiltration of multinucleated giant cells, and there will be scar formation, and fibroblasts will come in and create scar, which is permanent. And pannus is the condition that usually has to be surgically removed to enable a joint to work again. This is a very severe example of the destruction of joints from rheumatoid arthritis, and an x-ray to show you. You can see fusion of joints. These joints are actually fused together here and here. Look at the loss of that one. That's not the way the thumb should look, and that's the corollary of inflammation from the nodule formation. Here is scleritis. Did you know that rheumatoid arthritis can affect the white part of the eye? It's called scleritis, and that's what it looks like. This is an example of the wrist opened up surgically. This is the extensor retinaculum peeled back. Look at this nodule here on that extensor tendon, probably to the index finger. If this were the left hand, that would be index finger. Here's another nodule, here, here. Notice the difference between this leg and this leg in this patient. This is swollen. This is the same patient a few days later. This is a ruptured popliteal cyst, and this is the radiographic image of that cyst. This is all a big, bullous fluid sac that's all part of the knee joint tissues. What should be the synovial package that's neatly confining the knee joint is now blebbed out and has become a huge sack of potatoes, sack of fluid. It's just bulging and slipping down. And this patient's ruptured, and it went down by gravity down the leg. And therefore you've got pressure, stasis changes, poor oxygenation of tissues, and death of blood cells, hematomas, and so forth. Okay, I'm going to end very quickly here, so I'm going to throw a question. I'd like a little discussion on this one, because this is real controversial in Ukraine. in Ukraine. Should we tell our chronically ill patients that they're going to die? Should we open the discussion about this when we know death is near? What do you think? I'm going to ask somebody else. Hold on just a second. Yes, sir, at the back. You think yes. I'm going to stop you. I'm going to come back to you. Who else thinks yes?
I think
Got a few hands. Who thinks no? Be brave now. Raise your hand. You think no. Who else thinks no? You think no.
I think it's a family member.
I'm sorry?
It's a family member.
Family member? Is that what you said? Okay. I'm going to go back to the gentleman here. Why yes?
Because sometimes it's good to open up to the patient, tell the patient what the life is all about, what she's going, he or she is going to face. So that maybe the patient is chronically ill and this is not taking off the medicine that she will be taking. And so you can open up to them. If you don't do this, you may die.
If we've exhausted all of our treatment options and we're at that point where we really have nothing else left, they are going to die unless we have a miracle or supernatural intervention. And, if we know that's going to happen, then you're really talking to them not about other treatment options that they may consider, but about palliative care, pain control, the end. Now, let's develop the idea. Why do family members get the privilege of knowing that someone's going out into eternity rather than the actual person who's going out into eternity? Why does this work for you that way? Help me understand that better.
The patient is already dying, so there's no need of telling what's in the situation of telling he's going to die again. But
Patient's already dying. Let me just make sure everyone's understanding. You said that the patient's already dying, so they're not the one who needs to understand that death is imminent. The family needs to be prepared. Is that what you said? Help me develop that some more. I don't believe that. Keep going. You got to convince me. You got to help me here.
the family member are like, they are still healthy, but they can accept the bad news. But the other person on the other hand is ill already, so the bad news will make the situation worse.
You make upset the patient by telling them that they're going to die. I couldn't agree more. I do agree with you that can be dangerous, and I have been in situations in which we chose not to tell a patient. But I want you to know that the doctor up here standing in front of you who has treated many patients dying of chronic diseases, where they did die, almost everyone, I told them that they were preparing to die. And I told them in words like this. Listen carefully. Mr. Smith, we've worked along hard on this illness. He knows that. He's been the one who's having to come to my office and take all these medicines and do all this horrible radiation and stuff. We've worked really hard on this, and I appreciate both your partnership with me and your own willingness to go through all this. Our results have not been as good as either you or I would like. I'm kind of discouraged today. What about you? You give them a chance to say something. What do you think's next? Now, have I told the patient he was going to die? I basically did. The question is a loaded one, right? I said, what do you think's next? What's next for you? I want you to know something, Mr. Smith. I am here for you no matter what, and I'm here for you and your family. What do you want at this point? What can I do for you? You are just simply laying it open for the discussion to happen. You're giving Mr. Smith the opportunity to say, I think I'm going to die. And if he says that, you say, by George, you're right, you're going to die. It's probably going to be next week. Of course not. You never tell a patient when they're going to die because you never know. You may think you know, but I've been very surprised many times. So you say, well, Mr. Smith, I understand. How do you feel that way? I mean, that really makes sense to me too. Now, have I told them they're going to die? I've simply agreed with what they said. You see what I'm doing? Now that's called empathy. That's called walking them through the obvious. That's helping them prepare for death. Then I ask the question, Mr. Smith, what do you think? Do you think you're ready to face what's next? I didn't use the word death. I didn't use the word eternity. That's religious. That's church talk. I can talk church talk, but I said, do you think you're ready to face what's next? Well, Dr. Crane, I don't know. I just don't know. I'm so scared. I don't know what to do right now. I wish somebody could help me. Mr. Smith, I'm here to help you. Do you have a pastor that you trust? That's a two-part question. Do you have a pastor that you trust? Because if they have a pastor who's never talked to them and they've never talked, that's not a good fit. And you got to deal with that before you bring that person in. Do you have a pastor or someone who can help you spiritually that you trust? That's where you, as the physician, start gluing together the opportunities for them to prepare for death without you having to take your time in the office to do it or the full responsibility. Now, if the opportunity is right there before you and you can help them and walk them through a conversion experience and a salvation prayer, great. I believe that God chooses us, and I believe that He gives us choice. It's an amazing dichotomy that makes no scientific sense, but I believe both are equally true. And so in the scheme of this Mr. Smith is being drawn to the kingdom of God through this medical illness, and you are simply the navigator of the murky waters for him. You're simply pointing him to the way, to the light. See it that way, and you don't have to get tangled up with the yes or no part of this question, see? Now, I've just given you my philosophy. I respect you totally if you don't agree with me. I have a feeling that most of your professors in Ukraine are telling you, no, you should never tell a patient they're going to die. It may destroy them. It may cause them to die. It may upset them. It may condition them worse. Tell the family. I don't agree with them. So this is a very good entry to what medicine's all about. Full of controversy, no good question, no good answers. That's the way you're going to live the rest of your life. Not a lot of good answers. In conclusion, strive for excellence. Nobody likes a sloppy and careless doctor. Be the very best professional that you can. Show empathy, show compassion. Get down at the patient's level. Talk to them as your respectful equal. Help them to understand you are there for them. And be what you would want if you were the one in their shoes. Become a partner against disease. Help them find meaning by openly and honestly discussing God in a real and legitimate way. Don't preach at your patients. Thank you for being here. Thank you that you care. I'm proud of every one of you. I've enjoyed talking with several of you out in the hall today and tonight, and I'm happy to speak with any others of you who would like some time with me. Have a good meal. What's next, Rusty? Is it photographs? Is that